طيب نحن يعني 3 دقائق بس علشان بس أكثر عدد ممكن من الحضور وبعدين نبدأ إن شاء الله.
إن شاء الله.
ما شاء الله. شوف till now we have almost 63 attendee, which means that يعني ما شاء الله your reputation is worldwide, Professor Hosny.
They are all my friends, and most of them are being paid to attend. مش كل مرة كل الناس تبقى جاية تسمع دكتور مازن سنجاب، لازم برضه مرة كده.
طيب انت دفعت لهم كام علشان برضو انا اتبع نفس الاسلوب بالمستقبل؟
والله بص، the more the merrier، يعني هم كل ما يعملوا اعداد اكبر كل ما في انسنتيف اكتر، فانا قلت لهم حتى يدخلوا على العائلات وكده، فيعني لا whenever you're ready انا جاهز ان شاء الله.
Yeah, just 2 minutes. Now we have greetings from everywhere. This is our friend Jesus from Mexico. He says good morning.
Oh yes, different time zone. Okay. Yes. Yeah, we do have people from around the world. Ramon. Okay. Okay. We do have only 63 today, plus the panelists, which is me and you. So
no, the number is increasing. No worries.
Okay. No, it's okay. Whenever you want, we will start. We will kick off, inshallah.
Because actually, many depend on watching the video again on the YouTube. Because of time conflict, they are at work, a lot of things. فإن شاء الله صدقة جارية يعني إن شاء الله.
ربنا يبارك فيك، ربنا يكرمك. أخبار حضرتك إيه وأخبار الجو في دبي إيه؟
والله الحمد لله ما شاء الله. لسه الجو جميل جدا هنا والله ما شاء الله.
تمام.
أوكي. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Welcome everybody to this session of the Cornea series in Sinjab Academy Club. Actually, this session is distinguished because it is the field which I love, and because my friend, Professor Hosny, is the leader and in this field as well. So all of us will learn from him a lot. And I'm sure that the discussion will be very hot. And as I told you in the beginning of this session, that you will hear the opinions from 2 points of view, which will enrich the discussion. And at the end, both opinions will lead to the same result. So join me welcoming Professor Hosny, who is very well known. He does not need to be introduced, but just a brief introduction. Professor Hosny is Professor of Ophthalmology in Cairo University. He is a leader in the field of ophthalmology, not only in Egypt, but worldwide. His talks are very distinguished because they are academic and systematic. And in addition, he has publications in the field of ophthalmology. He participated in, and still participating in ophthalmology education. And we are honored to have him tonight. So thank you very much, Professor Hosny, for accepting the invitation. And we are all yours.
Okay, thank you so much, Dr. Mazen, for this very, very kind introduction. يعني طبعا it goes without saying that most of the things that Dr. Mazen just said were out of pure kindness and manners. أنا لا أستحق هذا الكلام خالص، يعني أنا راجل غلبان جدا أغلب بكتير من اللي قاله الدكتور مازن. دكتورة نانسي ازي حضرتك؟ She just joined us, Dr. Nancy from Jordan. You're muted.
Dr. Mazen, Assalamu alaikum. Looking forward to your talk.
So it is an honor to participate in this series under the supervision of Dr. Mazen Sinjab. Dr. Mazen Sinjab doesn't need any introduction whatsoever, and we are honored as well with the presence of Dr. Nancy Raqad min Jordan. And I welcome all the people from all around the world, especially Jesus, who told us good morning. And it is nearly 8 o'clock here from where I'm speaking, and at Mazen's side, I think it is 10 p.m., isn't it?
It is.
So it is pretty late for a good morning, Jesus, but good morning. So the main aim of this presentation has been crafted and modified over the past years. And when I started to formulate and put the slides together, I had only one thing in mind. When we go to any corneal meeting, when you try to read about keratoconus in journals, or if you go to any meeting, the main aim of any presentation is to go deep into the treatment of keratoconus, to give you updates of different modalities in treating keratoconus in the form of corneal cross-linking with all the advances in corneal cross-linking. Even now they're doing corneal cross-linking with rose Bengal, how much of the energy you should use, shall you use a customized cross-linking or the mosaic type, what about the boost and the oxygen? And they're all very serious updates, very beneficial updates. But when you hear a presentation about corneal cross-linking, and then you hear another presentation about intracorneal ring segments, for example, and the types of intracorneal ring segments and the nomograms, different nomograms, and the success with each nomogram. And actually, some people are die-hard fans of a certain nomogram, and some people, including myself, would use different nomograms for different patients. But again, you hear all about intracorneal rings in a presentation, or you hear all about cross-linking in a presentation. You can hear all about topography neutralizing techniques and surface ablations and smoothing of the cornea and selective higher order aberration treatment, and which higher order aberration is much more relevant and significant in patients with keratoconus. And this is a totally different presentation. You can go into much more advanced cases and speak about different corneal transplantation techniques and whether the femtosecond laser is beneficial in these patients or not. Shall you do a DALC or a penetrating keratoplasm? If you're doing a DALC, which type of DALC would you go for? Would you go to the visco bubble and air bubble, a predesematic DALC, and what are the pros and cons of each? But these are all sort of targeted presentations and targeted reads about different modalities. But there was a gap, and this gap was very evident in my mind over the years, over the past 2 decades or more, is that in spite of us knowing a lot and trying to know a lot about each modality in the treatment of keratoconus, there wasn't this sort of consensus among cornea specialists what to do in each patient. In other words, I would very frequently, I'm sure Dr. Mazen Sinjab has the same, I'm sure Dr. Nancy Raqad has the same, and I'm sure that a lot of you guys who are listening to this, they do have the same. You have a patient who has been roaming around, has been diagnosed with a keratoconus, he's a VIP guy, and he goes from one doctor to the other, from one cornea specialist to the other, and then he gets different opinions, and he sends his reports to someone abroad in the States, for example, and then he gets a third opinion. And actually, you can get the same patient a couple of times on 2 different days, and you will have 2 different decisions. Even you, the very same doctor, might change your mind about the management. And the reason that this happens is that, and this is justified, this is not malpractice, this is not a flip side of medicine, this is really justified for the very simple reason is that there's no like golden treatment for keratoconus, especially early keratoconus. Now, when a patient has like acute hydrops, it's a no-brainer. But when a patient has an early form of an ectatic condition in the cornea, then you will have different opinions. And if you apply any of these different opinions, then you will not actually be, how can I say this? You will not definitely get a marvelous result. But you will get optimal results, and this is a very, very important word. Now, remember this word, optimal results. You will get optimal results from one modality more than the other. Let's say, let's talk in a slang. If you're talking like this patient will benefit 70% from one modality, but 50% from the other modality, and 40% from the third modality, we're not talking about 100% in any of these. But I over the years, I tried as much as possible to formulate my sort of recipe that I know works best. And by best, I mean best, not 100%, but as much as I can do for these patients. And there's always a ceiling. And the more you treat patients, the more you are aware that there is a ceiling and there is a point where you have to stop. You have to stop. And this is something that you have to learn. And I've learned this the hard way. But one of the messages that I would like to convey today is that when you have something which is pretty much good, the patient is satisfied, everything is optimal, this patient has passed the tests with a C, don't try to make it much better, because sometimes in our quest to give the patient perfect vision, we lose what the patient has. So to develop this so-called wisdom or level-headedness, how to tackle a patient with keratoconus in different stages, I tried as much as possible to formulate my own recipe and to convey this recipe in this presentation. Now, what I'm going to say today is not God sent. In other words, you can beg to differ anytime. This is my experience and my word that I have to say on keratoconus. Sometimes one of us would do one modality of treatment and then he will end up with a catastrophe. Then he hates this type of treatment and he has a totally different opinion on the same patient. Now, it is really I'm not going into compliments now. I'm stating facts. It is a very, very good thing that we have today on the podium 2 heavyweights in the science, of course. I'm not talking about real heavyweights, Dr. Nancy Raqad and Dr. Mazen Sinjab. So I am actually looking forward to a discussion with them on what I do for in my patients for keratoconus. But over the years, I have changed a little bit in this presentation, and this is what I do for keratoconus. So let's start. Okay. So what do we do? What do we know? This is exactly what I have been saying. We know different modalities for treatment of keratoconus. We know different contact lens types. We know the rigid, the scleral, the hybrid, the Rose-K, the metro lenses, and we've used them all. And at one time, I used a lot of metro contact lenses. At other times, I used a lot of Rose-K. And the Rose-K, they have different types of contact lenses. And unlike the fact or the common consensus that contact lenses, especially hard contact lenses, are not tolerated in our part of the world and they are only made for the West or the Northern Hemisphere, basically, No, I have found patients that were very, very tolerant to hard contact lenses, and I like using them in many cases. Actually, I am one of the guys who used a lot of soft contact lenses, soft toric contact lenses, and I found great success with these patients in early keratoconus with this type of modality. We know a lot about corneal cross-linking, and now it is, we are doing corneal cross-linking for very thin corneas now. We've been doing it with an epithelial window. We have been doing it with a contact lens assisted corneal cross-linking. We are now doing the sub 400 protocol. The guys from across the Atlantic, the CXL USA trial have proven that actually the amount of energy that we stop at in fear that we can damage the corneal endothelium is not very true, and they are using 7.2 joules. And we know a lot about corneal cross-linking per se. Now, Ferry Hafizi in Switzerland is using now rose Bengal in corneal cross-linking. I've been one of the people in the study of the CXL Swiss study, in the PAC CXL Swiss study for corneal infections. But again, these are things that we know. We know a lot about each different modality. We know a lot about intracorneal ring segments. We know a lot about corneal transplants. But what we do not know is how to make a recipe for each and every patient. Why do we know this much about keratoconus? Actually, abnormalities in corneal shape have been in the spotlight ever since the late 90s, when they started doing real good topographies. At the time, of course, they were placebo-based topographies, but at the time, the indices came out, and we used to study corneal indices. And for the first time, we really appreciated what was the value of inferior superior disparity, and what are the key readings that we should stop at, what are the key readings that we suspect that this patient has any ectatic condition of any sort, not only keratoconus. Why did this happen? And before the era of refractive surgery, keratoconus was only one page in the book, one page in the ophthalmology book that we used to know. And we all knew the Rituzzi sign and the Munson sign and the very late signs of keratoconus, but we really were not very much interested into knowing keratoconic eyes that will become keratoconic corneas after some time. So they are like keratoconus wannabes. We did not want to know that. We're not interested. But the art of detecting the disease has developed mainly due to the refractive surgery outbreak. And this was back in the day, late 90s, and from the year 2000, of course, where keratoconus was contraindicated. So you have to know if the patient had a keratoconus or not, because if he had a keratoconus, then we should abandon him or discharge him from doing refractive surgery, corneal-based refractive surgery. And then came the emerging population with iatrogenic keratoconus, which is a very severe form of keratoconus that does not respect the rules that we've always known. And this is the post-LASIK ectasia. Now, the first case of post-LASIK ectasia has been reported in 1999 by Theo Zeiler. And from that time, there is like, if I can say, a pandemic of corneal ectatic conditions post-refractive surgery all over the world. So keratoconus itself, the good old naturally occurring disease, was not the aim, but all the advances that we did was to serve our refractive surgery practice. So we're good at detecting the disease, even in the most subtle forms. And there's a big debate and a big fight between die-hard cornea specialists between what is the definition of form first keratoconus and early keratoconus, and when you expect this and when you label the patient with that. And if the patient has a form first keratoconus and you're seeing this patient, following up the patient to know if his condition is progressing or not, what are the criteria for progression? So we are very, very deep into this. We know a lot about each modality of treatment separately, and we know a lot about detecting keratoconus with a lot of indices and a lot of different technologies that can actually depend on corneal imaging with very different modalities, either placebo-based, Scheimpflug, slit scanning, Now we have the ultra high resolution ultrasound. Very, very recently, there was the Brion's microscopy, which is an optical microscope that uses birefringence of light just to know if this cornea is normal or not. Now, very recently, there was a big grant given, $2 million, actually given to one of our colleagues in Bascom Palmer, Dr. Mohammed Abu Shusha. He's a professor in Bascom Palmer, cornea specialist, for doing a multi-layered wide field tomography in the cornea. So actually take the cornea layer by layer and do tomography for each layer. And this is an ongoing project. So these are all, we are deep into studying the biomechanics of the cornea. The Corvus has cast all other machines like the Aura, which used to measure the corneal hysteresis. So we know a lot about measuring the cornea, and we know a lot about treating the cornea. But what we don't know is how to mix these things up. Okay. So, for example, we are so clever at diagnosis of keratoconus up to the extent that this patient, for example, has a totally normal, 100% normal Scheimpflug image. And this is actually a Scheimpflug image, which is merged with a placido disc as well. This is a totally normal patient. We can actually do a ray tracing aberrometry for this patient and the very same patient and detect that this patient has a vertical coma. We actually know that vertical coma is very, very specific for keratoconus and very, very specific for the point spread function and the symptomatology of the patient than horizontal coma, for example. So we have like machines and topographers like the Sirius CSO that puts in the index BCV the vertical coma. It gives it a very big weight. So if the patient has just a little bit of increasing vertical coma, then the signal comes out that this patient most probably will develop an ectatic condition again. So we know this, but what we're not so good at is deciding which modality is more suitable for which patient and combining the right mix from our arsenal that will best serve each patient. And each patient is different from the next one. And having a consistent mindset. This is very, very important. You can actually treat the patients and you can treat them very, very well, but you can treat them with different opinions and treat them with different, how can I say this, with different mixes in the recipe. But this will end up with a problem. As I was discussing this matter with Dr. Sinjab once, with Dr. Sinjab once, and I told him that exactly like when we're training our younger colleagues to do a phaco, for example, then we will set the settings of the machine for the first 100 cases. We will give them the proper chopper for them, and we will not allow them to change anything until they do 100 cases. After 100 cases, you are your own boss. You can change all the settings according to your preference. But before doing 100 cases, you will not have what is needed to produce a separate opinion. So my main aim in this talk is to give you a format or a nomogram, if you may, or a flow chart, whatever you can call it, and you just abide by it and do not do anything else. For the first like 100 cases, 100 corneas, then you will have an opinion, you will have a say in it. Actually, I do change it a little bit, and sometimes I'm treating a patient and I know that I'm not performing what I preach. I'm doing something that contradicts a little bit my nomogram that I say it everywhere. So I don't think it is a good idea to change the nomogram, whatever nomogram you are using, until you have sufficient experience. And I would say 100 eyes is a good start. The other thing that we're not good at, and this is something that is very important, I think this is one of the very important messages of my presentation today, is knowing when to stop. Now, I have seen wonders. I have seen patients that are okay, that can see actually 6/9 best corrected visual acuity, and then their physician, their treating physician, decides to do a PRK on the cornea, and then you'll end up with either severe ectasia or you will end up with a haze, and you will lose the best corrected visual acuity. I have seen a lot of things that really should be left alone, that doctors with very good intentions, they wanted to give the patients their best service and decide, especially if the patient is pushing for this. So, and they try to give them the best service, but then they cross the line and they lose whatever the patient had. So knowing when to stop in treating keratoconus is an art and is something that really should be mastered by cornea specialists. So we will revisit the basics. Our primary aim for the patient that has keratoconus is to see more. So this is something that we should make our minds straight. Our primary aim for the patient is to see more lines on the chart. I know we can go on and on and on speaking about the modulation transfer function, about the contrast sensitivity, about the quality of vision. We can go on and on doing that. But our primary aim in treating patients with keratoconus is for the patient to see more. Our secondary aim is for the patient to see better. So in other words, in refractive surgery terminology or jargon, to decrease the coma, especially the vertical coma. There will be a ceiling to the improvement of both, of the amount of vision, okay, the number, and the quality of vision. There will be a ceiling. You cannot end up with your patient that started off having keratoconus and came to your practice seeking help. You cannot give him normal vision. Okay, this is something, except in some exceptions, but this is something. This is something. Yes, okay. This is something that you really should know, and this is something that you really should consent to. Okay, you do have your patients. You're trying to help them as much as you can, but you know there's at one point you cannot go beyond. And the enemy of good, of course, is perfect. So I would say we should not discuss each modality of treatment with its indications and complications. And this is very common in presentations and in meetings and in books and in journals and stuff. We should rather discuss each patient and what modality or which modality will push his vision to the maximum, again, which has a ceiling. Okay. 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 So I divide my patients, or any patient that has keratoconus seeking help in my clinic, I divide them into 5 categories, okay? 5 types. Type 1 patients, these are the patients with K values of 40 diopters to 50 diopters, which is pretty much within the normal range. But they do have indices that tells you that this patient has keratoconus, definitely. So they are diagnosed with keratoconus. These are not form-frusted keratoconus or patients that are going to have keratoconus. No, these are established cases with keratoconus, but with K values of 40 to 50 diopters and with good best corrected visual acuity. And by good, I mean 612 or more, 0.5 or more, okay? And this is best corrected visual acuity. This is not uncorrected distance visual acuity. This is the acuity or the vision with their glasses on, okay? These are type 1 patients. So what do I do for type 1 patients? Patients with good visual acuity should be offered cross-linking ASAP, okay? Now, I have written in this slide, in this first paragraph, unless over 40 years of age. This is very classic teaching, because classically, if you have a patient over 40 years, then the cornea then is naturally cross-linked, especially if the patient is a smoker. We do have a lot of smokers in this part of the world, unlike in the Northern Hemisphere, for example. But I've changed my mind, actually. I have seen a lot. These are not exceptions in my practice. But again, when you are running a tertiary practice where everyone sends you the complicated cases, then I don't have a real epidemiological real view of the keratoconic patients that are roaming around. So, but I've seen a lot of patients over 40 years of age with progressive keratoconus. So my tolerance now for cross-linking is very, very low. And what I tell the patients when they ask me, when should we do corneal cross-linking? And my classic answer is yesterday. So a lot of other very respectable corneal specialists would say, hold the horses, keep the patient under your eye, do him a tomography every like 3 months or 6 months, and there are criteria of progression. If the patient does not show these criteria of progression, then why do a cross-linking which has potential complications? From my side, from what I saw over the years, that more common than not, you will have patients slipping through your hands, through your fingers. You will follow them up for once after 6 months, and then another time after 6 months. The patient will have a full sense of security that everything's absolutely fantastic. I've been going to the doctor for the past year, and he's telling me that everything is fine and you're stable. And then he disappears for 2 years and comes back with aggressive ectasia. So my tolerance for doing cross-linking in these patients is very, very low. So these patients should be offered, in my opinion, cross-linking in order to keep their best corrected visual acuity, even if they're over 40 years of age. If a patient in this group with good visual acuity is not satisfied with his visual quality, then please offer contact lenses, preferably soft, spherical, or toric contact lenses. For these patients where they have best corrected visual acuity better than 612, for example, the patient seeing 6/9, I do not offer Athens protocol. I do not offer laser vision correction, except in a very, very few if they have a certain type of topography. I will not discuss in this slide at all. I would like to set the record straight that these patients, type 1 patients who have vision 6/9 or even 6/6, better than 6/12, should be offered corneal cross-linking and nothing more. If the patient wants to top up his vision, then offer him a contact lens, soft toric contact lenses or hard contact lenses. Do not push laser vision correction in any form, as these patients do have unpredictable corneas. Now, these patients, just picture this. These are corneas that have not been touched ever in their lives, and they are showing ectatic conditions. So please don't interfere with the dynamics or the biomechanics of this cornea, even with an ASA or advanced surface ablation, which we all know that does not affect the biomechanics of the cornea that much. Because if you do that, then you'll go inside the debate of whether to do a cross-linking with the procedure or not. And if you're going to do a cross-linking, how to do this cross-linking. We have different protocols. We have the Cretan protocol, the Athens protocol, the Dubai protocol, and every city has a protocol now. And if in some old dinosaurs like myself like to do corneal cross-linking first and then wait for like 3 months and then do a laser vision correction and then do a flash cross-linking at the end. So this is very, very debatable. But if you have a type 1 patient, again, type 1 patient is 40 to 50 in the case, and good vision. With his glasses, he's seeing 6/9, 6/6, or 6/12, then do not push laser vision correction and do a corneal cross-linking. Now we will proceed with with the keratoconus in severity. Now, as you get more and more into the disease, as the disease progresses, the decision becomes a little bit easier. For example, you will be surprised how many patients, how much of the cohort of patients that I call type 1 patients, okay? So these are again, just to recap, of these patients that come to me and they have done laser vision correction or they have done intracorneal rings. I've seen many of those. And when you go back to the records, you see that they are type 1 patients. And I don't think that doing them any more of the treatment modalities will give them more benefit, but will definitely increase a risk in and so unpredictable cornea. So going forward to the type 2 patients. So type 2 patients, or what I call type 2 patients, are the same. These are patients with early keratoconus, again, with values or with K values of 40 to 50 diopters. So no big deal. This is an early keratoconus. But when you try to gauge the vision, when you try to correct the vision, do the refraction, of course, refracting a keratoconic patient is an art. If you do a refraction and try as much as possible to boost his vision, and he cannot see better than 6/12. So this guy sees 6/18, 6/24. but he has a cornea K values of 40 to 50 diopters. This is a totally different kind of fish. In these patients, you can consider surface ablation. Why does the patient not see good or better than 612 or 0.5? Because he has loads of higher order aberrations, namely coma. The amount of vertical coma in these patients will give them so much shadowing and so much, not glare, but shadowing, that will affect definitely the modulation transfer function, the contrast sensitivity, and the quality of vision up to the extent that they will not be seeing even 612. Now, in these patients, I consider surface ablation, but although this is a surface ablation that looks like normal advanced surface ablations or PRK, whether if you're using trans-PRK or if you're using mechanical debridement, of using alcohol, of using Amoyle's brush, or whatever the way you are doing your ablation, this is not a patient that you should offer spectacle independence to. The main aim of the surface ablation is to regularize the cornea and change this patient into a type 1 patient, where he still has a prescription, but with the new prescription or with the same prescription or with whatever prescription, he will see better than 612. So your main aim is to transfer this patient from not seeing 612 to seeing 612 or better with glasses. So how can I say it? The paradigm of using this surface ablation is totally different from the refractive surgery paradigm, where you're actually trying to make the patient get rid of his glasses. Why am I saying this? Because you choose the optical zone differently. You choose the amount of higher order aberrations that you are going to treat differently. If you do have a platform that makes a choice about higher order aberrations and which one to treat and which ones not to treat, then you will aim to treat the vertical coma. You will not be very much interested in treating the spherical aberration, because in these patients with a hyperprolate cornea, they will have loads of negative spherical aberrations. So if you go and try to treat the spherical aberration in these corneas, and this patient has a keratoconus with a thin cornea, then you will dig too deep into the cornea. You will induce ectasia, definitely, even if you're doing a surface ablation. So in these patients, the main aim is to regularize the cornea and to give the patient prescription to see better than 612. Okay, but sometimes in your quest to regularize the surface of the cornea, you will induce a spherical error, okay? A spherical lower order error that can be compensated very, very easily with spectacles. But the patient will not absorb this that much, because if the patient, for example, starts off when he came to you with a prescription or with glasses that were like -3 sphere and -3 cylinder, okay? But with these glasses, he used to see 636. And then you decide to do him regularization of the cornea with a PRK. And the patient ends up with a -5 sphere and a -1.5 cylinder. And he can actually see with the -5 sphere and the -1.5 cylinder 6.9. Okay? He will not be that happy, because he will always look at the prescription, his prescription preoperatively and his prescription postoperatively, and with time he will forget the fact that he did not see that well with the previous prescription. So in these patients, our main aim is, number one, to regularize the cornea. Number two is not to induce a spherical error. This can be done by very different techniques. There's something called a topography neutralizing technique, where you neutralize S4 and S12. I'm not going into these details at all. The main thing for you to know is that I'm going to regularize the surface of the cornea with whatever I'm going to do with the surface PRK, with the main aim to change these type 2 patients into type 1 patients, where they can wear the glasses and see 612 or better. So the primary aim is not treating the refraction with the PRK, although you can partially achieve this, most of these patients, we can pop in some of the refraction without digging much into the cornea, and they will end up with a much less refraction than what they had preoperatively. And this is something that we do all the time. But again, this is like an extra present. This is something that you get more for your money. This is not the main message or the main aim of your treatment. The main aim of your treatment is to change this patient into a patient who wears his glasses and sees better than 6/12. So always combine your PRK, your surface ablation, with a cross-linking at some point. Many protocols are described, including the Athens protocol. I'm not a big fan of Athens protocol, but again, put in your mind, you're going to do a surface ablation and you're going to do a cross-linking with whichever protocol. I'm not digging into this. I have a separate presentation about the pros and cons of each approach. But for you to know, type 2 patients, where the patients have 40 to 50 K in the case, and they cannot see well with their glasses, then these patients, I'm going to do a combination of surface ablation and cross-linking as well. If you can obtain a reproducible aberrometry, then go for wavefront guided ablation. If you have selective higher order ablation treatment, then treat the cornea only. If not, do a topography guided ablation, a TCAT with topography neutralizing techniques. And again, this is a different story that we can discuss later on. I follow my ablation with a cross-linking again after 3 months, and I prefer cross-linking before and after the PRK. But again, these type 2 patients, I'm going to do advanced surface ablation plus a cross-linking with any of the established approaches. So these are type 2 patients. Always remember, your aim is to transform these patients from type 2 patients to type 1 patients, okay? And success is reached when their best corrected visual acuity is 6/12 or more with glasses or soft contact lenses. Type 2 patients can also benefit from hard lenses, but when tolerated and when properly fit, these lenses are godsend. They are very, very good, especially the scleral lenses can provide superb quality vision. Okay, so these are type 1 patients and type 2 patients. Patients with K values of 40 to 50. Type 1, they can see well with their glasses, see 6/9 with their glasses. And these are the patients that you will go for cross-linking only. Type 2 patients, they cannot see with their glasses. So these patients need regularization of the cornea plus a cross-linking. So what if the patient has a more progressive disease and enters into the zone where I call the patients type 3 patients? And these patients with K values of 50 to 60 diopters, okay? These are usually the patients for rings, for intracorneal rings, okay? The main aim is to centralize the pathology. We all know that it is a little bit out of the norm. We see it, but this is not the normal thing, is to get a keratoconus, which is bang in the center of the cornea. Sometimes you see this, but this is not the rule. Usually keratoconus, as we all know, has a sagging cone. It's a cone is usually moved or transposed on the cornea, on the surface of the cornea inferiorly. And most of the keratoconic patients are like this. But the aim in these patients, if they have so irregularity in the anterior surface of the cornea that is affecting the vision with K readings from 50 to 60, our main aim is to centralize the pathology, even if it is ectatic, and try to flatten it as much as possible. You will not be able to flatten it to normal values, but try to flatten it as much as possible. And you can do this with a combination of intracorneal rings and cross-linking. Again, there is a huge, big fight and debate about what to do if you do a cross-linking first and then do the intracorneal ring segment, or would you do an intracorneal ring segment first until the cornea changes its shape and biomechanics and sort of lock in your result with a corneal cross-linking afterwards? Or would you do a combined approach where you put the rings and do a cornea cross-linking at the very same time? Or even you can do an intratunnel inside the tunnels of the rings, riboflavin injection, and do an intratunnel cross-linking. And if this is good or bad, and this is a big, huge debate. We have did a study comparing simultaneous tunnel cross-linking with intracorneal rings versus intracorneal rings with epi-off cross-linking. And this has been a publication. We published this, I think, 5 or 6 years ago, and we didn't find really big difference between this and that. But again, you can find different studies reporting different results. But these patients, type 3 patients, where you have from 50 to 60, you always think rings. And rings alone, no, rings and locking the effect of the rings with a cornea cross-linking. So again, you have a type 1 patient where the patient has keratoconus, definite keratoconus, not a form frustic keratoconus, not a posterior increase in the posterior corneal curvature, not a big Bellin-Ambrosio display number, not a big D value. No, these are not patients who are a keratoconus suspect or a keratoconus wannabe, or a patient that will develop keratoconus in the future. No, I'm talking about established, diagnosed patients with keratoconus. If they are from 40 to 50, then you have 2 types of patients that see better than 612. Then these patients lock in their vision, press the button of stop on the pathology by doing a cross-linking. If you have a patient that does not see that well in spite of having the K readings between 40 and 50, then you have to regularize the cornea and lock in the vision with a cross-linking. If you have a patient that has from 50 to 60 diopters, and these are the patients for intracorneal ring segments. Again, you have to combine this with a cross-linking in any sort of modalities. Okay. Many combinations have been described using the intracorneal rings with cross-linking. We used to say that better intracorneal rings first or simultaneous cross-linking with corneal rings. Recently, intratunnel corneal rings have been recommended. Different rings are available. We can talk for like hours and hours about the pros and cons of each ring and the cross-sectional design of each ring, and how does it affect coma, and how does it affect the pupil, and how does it affect the corneal pathology itself. Different nomograms are available when you're popping in an intracorneal ring. You can use the nomogram based on K readings. You can use the nomograms based on sphere and cylinder or the spherical aberration. Again, your aim at the end is to allow this patient to wear glasses over his rings and see 612 or better. So all of our aims in treating keratoconic patients, whichever the stage that you find the patient in, is to push them back to type 1 patient, where the patient is between 40 and 50, has a locked-in treatment of any sort because he is cross-linked, and he can see with his glasses 612 or better. Okay, I don't think we can do better than this in the status quo of medicine or ophthalmology for keratoconic patients. As the disease progresses, the decision becomes easier and easier. So the patients who I call type 4 patients are patients with K values of 60 to 70. Now, having said that, we've all done a lot of patients with 60 something K readings. We've done them rings. And we have reported good results. Actually, these patients report very good results if you have 62K or 60, even 64K, if you have enough corneal tissue, of course. But this is not the rule, okay? The rule is that if you have a 60 to 70 diopter cornea, then these are type 4 patients, and these are the perfect patients for a deep antilamellar keratoplasty. Except if they have regular central cone, and this is something that we saw every now and then. At one point, we have a publication on the Meyer ring, and the Meyer ring is a complete ring that actually is introduced inside the cornea with a lamellar pocket. And in these patients, in the patients who had a keratoconus, which is a very central pathology with good corneal thickness, especially peripheral thickness, we put Meyer rings in these cases, and we had very, very good results. I have autorefractometry screenshots of patients that became like 0.25 cylinder after popping in a Meyer ring, and we reported very good visual outcome. But again, these are patients that you encounter every blue moon. And in my case now, a lot of the the refractive surgery jargon from our colleagues are sent to me. So I have a lot of patients who have corneal ectasia. And in these patients, even if they have a naturally occurring ectasia in the form of keratoconus, he has been around, he wanted to do LASIK, and he was discovered to have keratoconus, so go to Muhammad, and then he comes to me. In these big population of keratoconus that I'm actually dipped inside, we don't see the patients that have a central cone with exceptional pachymetry a lot. We see them, but these are not regular patients. If you do find one of them, then go for a MyRing, of course. If they have a pachymetry less than 300, then do a PKP. Now, this is something that I do, but I preach, but I do not do. I have done DALCs for corneas which were much thinner than 300. But again, if you are kicking off with the practice, please do not intend on doing a big bubble in patients less than 300 microns, because most probably you will not get a good separation of the Descemet's membrane, at least at first. Okay, so going back, type 4 patients, these are patients with K values from 60 to 70. Very easy, no brainer. These patients you do a DALC for. Now we can go on and on. Which type of DALC should you use? I'm a big fan of femtosecond mushroom DALC, and I have the special technique, and we have all the tips and tricks of how to do it. But again, just do a DALC for these patients, type 4 patients, where they have K values of 60 to 70 diopters. Now, type 5 patients are a no-brainer at all. These are patients with K values more than 70 diopters with central scarring. You know, these patients where you take a look at the pentacam and you find that the central part or the lower part is not even red, it's black. Okay, so you have a central black area in the pentacam because the K readings are just blown through the roof. So these patients, you go for a PK. I do definitely a femtosecond assisted mushroom in these patients. Large grafts with anterior diameter of 8.75 to 9 millimeters. You follow up with the cylindrical package correction. This is something else, whether to do these patients topography guided ablations after 1 year after removing the sutures, or to do these patients femtosecond arcuate incisions. Now, remember that your ceiling always is to push these patients who had K readings 70 diopters or more back to the slot, back to the square of type 1 category, where the patient will need glasses and will see with his glasses 612 or better. Okay, so always remember the 300, 350, 400 rule. I used to put this in my mind. No Dresden's protocol of pachymetry less than 400. This is classic. We now do a sub 400 protocol, but definitely it's not the Dresden's protocol. Sub 400 protocol sometimes is so funny that in some pachymeters, if you go by the nomogram, it's like a minute and a half of irradiation. No intracorneal ring segments if the center is less than 300 and if the site of implantation is less than 400. And really, this is rare because you will always find the site of implantation which is in the peripheral cornea, in the mid-periphery of the cornea, like 8 millimeters out. You will always find it more than 400. And no MyRing if the thinnest area is less than 400 microns, and no DALC if the thinnest area is less than 300 microns. In conclusion, we have a lot of weapons in our armamentarium for the management of keratoconus. I would suggest for everyone to categorize the patient first and then pick your procedure accordingly. Then when you pick your procedure, you go deep into the details of this choice. Thank you so much.
Thank you very much, Professor Hosny. Fantastic as usual. Really, it is a great lecture. Let's say that categorizing the patient is the core message and the core, let's say, treatment or the first step in knowing how to treat the patient with keratoconus. Because as you mentioned in the beginning, that even the surgeon himself, if they see the patient today and then they see the patient maybe after 1 week, 2 different decisions for the same surgeon. So what to say then the differences between or amongst the surgeons, but by the way that you presented the algorithm, let's say, you could build a way of thinking, let's say, starting from categorization, then going into deep for other parameters like the K readings, like the corneal transparency, like the visual acuity, and so on. And of course, when you apply, even when you apply your algorithm, maybe you will find in some cases that you may find two decisions based on your algorithm. You may say, maybe this patient may get benefit from the corneal rings, and maybe this patient may get benefit from going to customized laser vision correction. Yeah, and here the experience plays the role. The long experience plays the role. So actually, thank you very much for this comprehensive, and we learned a lot from it. Now, we planned that I will present my part, but I think it's late. So we may plan.
I'm sorry, I know I took a lot of time. Wallahi, I'm very, very sorry.
No.
Sinjab, honestly. We had this plan. We had this plan, me and Dr. Mazen, just for you guys to know, that we will play like a good cop, bad cop. So I will be saying this, and then he will give another presentation that shows that everything that I said was just not valid. So we had this plan going, but I couldn't help myself. I speak a lot. This is something that I've been working on for the past 50 years. I didn't get any good treatment until today. So I'm sorry. I took long in one presentation.
No, Dr. Hosny, actually, I'm very pleased that you took your time to give us all this knowledge. We learned a lot, and I'm sure that the audience learned a lot from you. So we can plan, no problem. We can plan another session where I can show my own way, which is the functional approach. I can just start sharing only few slides, just an introduction to my way of thinking, and then I can go into detail later in another session. We can plan it together. And of course, we are very happy to have Professor Lou with us as well. Thank you very much, Professor Lou, for joining us, and Dr. Nancy as well.
Thank you very much. May we speak?
Yeah, of course, please.
Yeah, thank you, Dr. Mohammed Hosny. Actually, this is an amazing amazing way of simplifying things that we practice every day. So I've been involved in a on-site lecture, and I've just left everybody just to sit and listen to you talking. And I've completed your talk on the way. As you see, I'm driving the car, and I just stopped to really congratulate you on the way, how basic and how straightforward and how categorizing things make things seem so in place. I want to thank you very much for this excellent or great way of putting things together. I've enjoyed every part of it. And now maybe we can have a look at Dr. Mazen's presentation. I'm very happy to be here.
Nancy, for the nice words, but you're a nice person. That's the...
Oh, no. You're being too humble now. Really enjoyed it.
Okay, great.
Thank you.
Yeah, thank you, Dr. Nancy. Let's say, dear friends, correct me because I'm learning from you now. Actually, my way of thinking has changed over the 2 decades, as Dr. Hosny said. By the way, Dr. Hosny and I are just same age, but he looks younger than me. Great. So actually, regarding the treatment options, we all know that the treatment options include the glasses, contact lenses, cross-linking, customized laser vision correction, rings, segments or full rings, phakic IOLs, toric phakic IOLs, and corneal transplantation. Great. Now, previously, maybe many of the audience had gone through the Keratoconus series in Sinjab Academy, which I think is composed of 16 or 17 videos taking the keratoconus from A to Z. And my way of thinking at that time was like, to discuss all of these options based on 12 parameters: the transparency, the presence of vox striae, progression, age of the patient, gender of the patient, corneal thickness, Kmax, refraction, amount of astigmatism, visual acuity, and potential visual acuity measured by the contact lenses and high order aberrations. But I found it very sophisticated and very complicated, especially for beginners. So I developed my own functional approach based on vision, purely on vision. When vision is good, let's say vision may be good, may be poor, but good with contact lenses. So we say good potential visual acuity, or maybe poor and stays poor with the contact lenses. So poor visual acuity, potential visual acuity as well. So whenever it is good, I say it is grade 1. Whenever it is poor, but with good potential visual acuity, I say it is grade 2. And whenever it is poor, but stays poor with a potential visual acuity, I say it is grade 3. So only 3 categories, all right? And of course, when you go through the literature, you may find classifications including 4 stages of keratoconus. Mostly they are 4 stages of keratoconus based on corneal thickness and K readings. And today we learned from Professor Hosny that keratoconus is 5 stages based on his algorithm. Now, I found functionally it is more practical to consider it as 3 categories only. Now, how to define each one of them? When visual acuity is, let's say, moderately good, and the symptoms are mild, visual acuity, corrected visual acuity is more than 0.6, and there is a reasonable difference between corrected visual acuity and uncorrected visual acuity, more than 2 lines, and usually this is associated with RMS comma, which is less than 2 microns, then it is grade 1. Usually these criteria come together, usually, all right? But the core is the visual acuity, all right? Now we come to examples. So we may find different patterns on corneal tomography, but all are classified as grade 1. So no longer I'm depending on the pattern of the tomography to say this is grade 1 or 2 or 3. I will depend on the pattern later whenever I would like to do, for example, customized laser vision correction or intracorneal rings after I make the decision, all right? So this is grade 1. As you see, the comma is only 1.4. This is another example where it is grade 1 as well. And this is grade 1 as well. So different types and patterns of corneal tomography, but all are grade 1. Now, grade 2, where vision is relatively bad, but whenever we put the contact lens, the vision becomes perfect. So poor visual acuity, poor means it doesn't, the spectacle corrected visual acuity is not good, but with the contact lens is good. So moderate symptoms, the potential visual acuity is more than 0.6, and there is a reasonable difference between potential visual acuity, which is the visual acuity with the contact lenses, and the corrected visual acuity, which is the visual acuity with spectacles. So there is a reasonable difference, more than 2 lines. And usually the RMS comma is between 2 and 4, usually. All right, they come together, but the main core here is the visual acuity. So this is an example where it is grade 2, and this is a pattern which is grade 2. This is another pattern which is grade 2. Look at the difference. Kmax here is 61.5, and here it is 56.7. All right, but both are grade 2 because of the visual acuity. And this is another one, different types of cones, different places of cones. This is advanced one. This is eccentric one, and this is almost peripheral one. Now, grade 3, where the vision is bad with glasses and is bad even with contact lenses. So even when we put contact lenses, there is no improvement. So we say that this is grade 3. Severe symptoms, potential visual acuity less or equal to 0.6. There is no reasonable difference between the contact lens and the spectacles, and the RMS is usually high. All right. So according to that, I categorize the patient. Sorry, this is grade 3. We have different types and different patterns. Look at this pattern. Although it appears mild keratoconus, look at the K readings, only 50, all right? But the cornea is very distorted, and we tried a lot of times to take the capture of the patient, but we couldn't because the cornea is very distorted. Although the K readings are moderate. So grade 1, 2, 3, and this is a summary of grade 1, 2, 3. Now we come to the treatment options. I categorize the treatment options into, this should be, okay. Now I categorize them into aiding measures, corneal remodeling, and corneal transplantation in order to make it easy to make a decision. What are the aiding measures? They are contact lenses, glasses, or phakic IOLs. Corneal remodeling, where we need to remodel the cornea to change the shape of the cornea, either by laser or by intracorneal rings. And the third category is corneal transplantation. Okay, so in grade 1, because the vision is good, so we can go to the aiding measures, either glasses, contact lenses, or phakic IOLs if the refractive error is high. But in all cases, the vision is good. Now, we may need sometimes to enhance the cornea, to improve the shape of the cornea first, either by laser or intracorneal rings, and then we may go after that to the aiding measures. Now, in grade 2, yes, in grade 2, where vision is poor, but with contact lenses is good, we may go to the contact lenses and that's it. We don't need anything else. Or we can go to the corneal remodeling, and here it's very important. I always send any patient with keratoconus to contact lens fitting. I have an optometrist trained for contact lens fitting to check the potential visual acuity, because if it is good, means that the cornea has the potential to improve, and the vision will improve after I do the corneal remodeling. Otherwise, if the potential visual acuity is poor, then if I do any corneal remodeling measure, then there will be no improvement. This is why if the potential visual acuity is good, then I will be reassured, and I will have the self-confidence that if I do this to the patient will get a result. So either I go to the contact lens, as I said, or we can go to the corneal remodeling to improve or to enhance the shape of the cornea, and then we go to the aiding measures. Now, in grade 3, of course, we can go to the corneal transplantation. And after corneal transplantation, we may go to the aiding measures, or sometimes we may do a touch-up over the transplant, okay, by laser, not by rings, all right? Why not by rings? Because of the risk while inserting the ring to open the interface, the junction, and even if you plan to do that by femto inside the graft, you may harm the graft, okay? And in addition, there will be unpredictable results with the rings in the graft. But with laser, we may go for some touch up. And the meaning of laser, it is not only Athens protocol. We have a lot of things that we can do by customized laser vision correction. The simplest is to go for PTK, for example. If it is irregularity, we can just do PTK and everything will be much better than the irregularity itself. So I will stop here actually. I have a couple of cases to apply this algorithm on, and you will see how to select each one based on other parameters. After I get the decision, okay, we have to go to remodeling, for example. Okay, so which one of the remodeling, is it intracorneal ring or laser? Then I depend on other parameters, like, for example, the K readings, the corneal thickness, the amount of refraction, amount of astigmatism, and other parameters. So this is my way of thinking, and I hope that you enjoyed this.
Dr. Mazen, that's a very, very nice talk. That's a very nice talk. I'm actually very much interested in hearing it again with the case presentations or the case examples, please.
Yeah, sure, Dr. Hosny. So if you, I will message you, and then we can decide on the group with Professor Lou, Dr. Nancy, what is the best time to do another session, maybe next week if you have time. It will be great. I will show you, yeah, interesting cases of how to apply this and how to apply the parameters to select under the category itself, remodeling or let's say the aiding measures, for example. Professor Lou, we want to hear your voice.
Hello. Very nice to see all of you. I'm sorry to be so late, but I was returning from London and I was on the train, so I couldn't really tune in. I don't have anything to say, really.
Dr. Nancy.
Thank you very much, Dr. Mazen. It's again a wonderful way of putting things clearly. I think, yeah, maybe we can arrange something like case-based, as you mentioned. It would be very beneficial for everyone because sometimes applying the knowledge, everything to every case selection and the treatment option and how we think, showing how we think is maybe something that everybody would benefit from in an interactive way, as you said.
Yeah.
Yeah, we can arrange something like that.
Thank you very much. How about next Tuesday? Good? Good for all?
It's okay for me.
Fine. So if you like, we can make it like this, 6 p.m. GMT.
Mm.
Yeah, good. I think
Yes.
After the clinics, I think it will be 8 p.m. in Amman and Cairo, right?
It's 9 p.m. Amman, yes.
9
But it's
p.m.
fine.
So yeah, it will be good. Okay. So
I think I can do 6 p.m. to 6:45. Then I have to drive somewhere.
Fantastic. Thank you very much, Professor Lou.
Well, see you next Tuesday then.
Okay, yeah. Good.
Sure. Thank you very much.
Thank you.
Actually, I would like to thank the audience for attending, and I would ask them if they allow us to answer their questions after the session that we are planning on next Tuesday. Why is that? Because many of your questions will be addressed during the case discussion. So no worries, we are with you, and we will address all your questions, inshallah. Thank you, Professor Hosny, for the wonderful talk, actually. And thanks to Professor Lou and Dr. Nancy for their presence, which empowers us personally. You empower me when I see you attending the sessions.
No,
Thank
that's
you.
an honor, actually. Thank you.
Together.
Too kind.
Thank you.
Okay, great.
Good night.
Good night, everybody.
Good night,
Assalamu
everyone.
alaikum.
Bye.
Bye.